And we are proud that the National Data Center will play a very critical role in making this possible. My last slide indicates several possible businesses that can be looked at as health technology, and this includes mobile health, remote care systems that can guide patients from home. So there are fitness and so many opportunities in the healthcare. And this is some of the things we are looking at the various stakeholders within our country to come, and we are ready at Concert Technopolis to collaborate and avail the national data system and the innovation ecosystem within Concert and the nation to make this possible, and of course working with the other actors within the national innovation ecosystem. So with that, those are the few remarks I needed to bring to this webinar as we discuss and give ideas on how we should go forward. Concert Technopolis is ready to support you and to walk this journey together as a nation. Thank you, and now back to our moderator.
Thank you, CEO, for your opening remarks. Just as a matter of protocol, I would kindly request that if we are not speaking or if not invited, please have your video muted. I think this will allow ourselves to have an environment that enables us to focus on the speaker or the presentation at hand. So we can see, I think we have Newton Adika, if you could kindly mute your video, I think that would be very much appreciated. Just as we go on, again, I'll ask the CEO to kindly invite our keynote speaker so that she can address us. Thank you.
Thank you, Josephine. It's my great pleasure to invite our keynote speaker, who is the PS Ministry of Health and has been in the telecom industry, so she's quite familiar with the two areas, technology and also health. So she's the right person to speak to us today. And without much ado, PS Karibu.
Thank you very much, Mr. Tanui, and thank you for having me here. So I am just going to share with you about how technology and health innovation has served us during this COVID, and how we see technology continuing to play a very critical role and a central role in the management of our healthcare systems and generally our management of patients. So I don't know whether I am able to control the presentation from my end, or the Secretariat will move to the next slide.
Yes, Madam PS, we will support you. So we will move as you direct us.
Very well, thank you very much. So if you look at the next slide, really, we have been running a very big operation in preparation, or rather in response to COVID-19. We have been having various subcommittees that all speak to a national task force that has been meeting every week and giving advice to the National Emergency and Coordination and Response Team. What you are seeing before you is just there's a little of what we picked up where we have seen technology come to provide our response much more efficient. Because I could talk about so many other things, but this is just a few, because in total we have about 12 subcommittees all dealing with various critical work streams related to COVID. So in regards to risk communication, we are typically just talking about the usual engagements we are having on the social platforms and using your more conventional technology platforms to communicate. case management and capacity building. We've been able to escalate this and upward through technology. And I think rather than me going into a lot of detail, I see we explained more on the next page. So for risk communication, for example, we have been able to have coordinated messaging through an interagency approach and using MOH approved messages. And we've also, as I said, used your conventional TV and radio and social media to reach millions of Kenyans daily. Because a lot of what we do in terms of response is heavy sensitization, a lot of communication to change behavior. We have seen more people, beginning to adopt washing hands, which typically was not there. We've seen people wearing masks and really just influencing the way people are socializing, because that is needed in prevention. And all this communication has largely leveraged on technology. We also have a call center that is manned both by customer care support at Safaricom, but we've also placed 50 doctors who are there on 24-hour basis, so that as Kenyans are calling with respect to COVID, the very basic issues can be addressed by the customer care teams, but the more technical issues are then addressed by doctors at the back end. And that could really not have been realized if without technology. So on a daily basis, we receive about 3,000 calls, and we hit over 30 IVRs on a daily. In addition to that, we also offer emergency operation support, and this means we have to work very closely with counties. We are also providing psychosocial support. As we have seen, some of the challenges around COVID is the state of mental health. So we have a support line, the 1199, and it has also been used quite widely by the population. In terms of case management, it's just to note that we have been able to ensure there is patient record management on a digital platform, which becomes very useful, particularly to the researchers. They are able to quickly get information, and even for us as the Ministry of Health, we get real-time information, which allows us to be able to disseminate this information to the public. And in addition, one of the beautiful things that I have seen technology do with, for the sector is bringing together different cadres of health workers who meet at least twice weekly on webinar sessions, just to talk about the management and the practices of clinical management generally to the patients, because this is a disease that is new, nobody understands it, and the contexts and circumstances surrounding the virus are very different from country to country. So we have seen out of this webinar, Kenya being able to find its own solutions on how it will manage corona. So we have set out our own case management guidelines based on our own experiences and how our own patients have responded to the different medications. And I don't think that would have been achieved if we did not have technology allowing for doctors, nurses, clinical officers talking every other day and sharing their experiences and enriching their overall capacity. We are also, of course, in terms of capacity building, the professional associations within the health sector have taken up a lot of their training on online, and so health workers are able to access and get some training which is already uploaded, because part of the challenge with a situation like this that no one anticipates and no one is really ready for is being able to ensure that all the health workers are properly equipped in terms of information to allow them to effectively serve, and also ensure that they are safe as they are dealing with patients that have got this very deadly and contagious disease. I would also say, in terms of just coordinating our overall work, we have a command center, an emergency operations center in the ministry. We have a command center at a national level, and all these speak to each other on very important information sharing because of this. And I must also point out that part of what technology has helped us to do is the tracing of people who have been in contact with the patient or with individuals who are carrying the virus. And so far, we've registered more than 3,500 contacts, all these facilitated by technology. And we've been able to reach out to these individuals, and amongst them, we have picked some who have been infected, and therefore ensured that the spread is quite limited or even stopped in certain clusters where perhaps we would have seen more people getting sick. So on a daily basis now, we are tracing almost 600 contacts, and the response rate is at about 80%. And again, I don't want to overemphasize, what that has meant for us. But just earlier on there, in terms of incident management systems, all these documents that are listed there, the traveler surveillance forms, the case management investigation forms, quarantine forms, all these again are available to the counties as well on the digital platforms. In terms of laboratories, we have invested as a country quite heavily in ensuring that we have enough capabilities to then respond to HIV and TB. So really at a moment like this, Kenya is so well positioned because of the fact that during the time that HIV and TB became, pandemics in their own way and epidemics in our country, we ensured that we built the infrastructure, which is now supporting us in the COVID response, because we have repurposed the infrastructure for this. And in fact, the other day, our lab technologists were sharing with us that the capacity of Kenya in terms of laboratory is more than the whole of Europe combined, because those countries don't have to deal with some of these highly infectious diseases such as HIV and TB at the rate that we do. And so these labs of ours are interconnected. They have been able to ensure we get real-time information. Some of them are highly advanced. So the entire processing is on electronic process, which means that the margin is very, very limited. We've also, perhaps I can say that we have got our own research that is going on, and by various partners, and Kenya is participating in some of them in line with the necessary protocols. In terms of logistics, I do not want to emphasize the role that technology plays in helping us manage our inventory and know how the stocks, and particularly the ones dealing with COVID, are moving. But generally, even before COVID, KEMSA has got quite a robust system that is able to, take stock of what is going to all the counties and track them. The only thing is that we have not achieved the complete last mile, where we are keen to know when products reach counties, then what? How is the utilization? So we are now at that point, but of developing those tools. I'm also happy to say that, the headache of managing and oversighting donations has been taken away, because we are now tracking what we receive in donations and the distribution through technology. So again, easing our work and helping us to achieve transparency and achieve accountability in the support that we get, and inspire confidence to the partners that deal with us. In terms of, technology as a driver to UHC, because even as we deal with COVID, one of the key pillars of the country's agenda, economic agenda, is to realize universal health coverage, and we are still on the course, even as we deal with COVID. And really, our aspirations are clearly outlined there, to basically ensure that Kenyans are not impoverished by a high burden of cost care expenditure, and making sure that the Kenyans have access to facilities, and that really we have more health workers, so that we can efficiently serve Kenyans. So we are now looking at how technology will help us to leverage on looking at some of the key intervention areas for us, how we will use health financing or provision of health insurance to the citizens using a unique identifier, that is Huduma number, and being able to manage the health insurance through the use of technology. We are looking at having e-referral systems. We are looking at having electronic health records, e-learning, telemedicine, health information systems. All these are not just, they are just not cliches for us. We are working very hard to see that as part of UHC, Kenya moves the health agenda forward with technology being the key driver. And I must recognize at this point that, having been in the ICT sector before and having worked in several ministries, I have come to realize that actually health is a laggard in terms of technology. A lot of systems and processes are still very manual. So we have a big responsibility to ensure that we do, catch up and fast track our aspirations because of technology, which provides several solutions to us. Again, this next slide talks about the UHC, and I think I won't re-emphasize because it is almost repetitive of what I have said, but just to bring us to speed in terms of what we have achieved, we have 45 counties that have already signed the intergovernmental partnership agreements to roll out the UHC. We premised the UHC program around lessons we learned in the 4 pilot counties that we've been running for almost 8 months now. And we are basically focusing UHC on being very patient-centric and ensuring that we have quality health data, just as I had mentioned earlier. And we are on course even in the midst of Corona. In terms of the healthcare structure, you can see this gives you a sense of, there is a pyramid. Secretariat, you can move forward. I am way past the slide you have. Secretariat, okay. Move on. Okay. Sorry, I'm having my own laptop, so I know you are having a challenge to keep up with me. So yes, that is where we are. This just gives us a visual impression of what the healthcare system in Kenya looks like, starting right from the community health units. This is the very primary level of health facilities in the country. And the community health units here are simply the community health volunteers who are such an important backbone and pillar for healthcare in any country, and specifically for us in UHC, because we lay emphasis on prevention rather than curative interventions when we are talking about UHC. And so it is an area where we really focus on to have these community health volunteers all kitted with phones that allow the capabilities for them to communicate and to have exchange of data. The other thing to note is that then we have the health centers and the dispensaries, and it is our hope we are going to also connect these facilities through technologies. And at this level, we are just looking at using simple, basic mobile phones to have information, calculating upwards. And then we have the level 4s, the level 5s, and finally, we have the tertiary hospital, that is our national referral systems, who offer the more specialized care and the training research. So when we think about ICT, think about having a seamless interconnection between all these facilities and leveraging on that to ensure better patient care in the country. We can move to the next one. Again, here I see we are focusing on what we are currently working on, which is the essential health package. What package is this that we want to offer Kenyans at UHC? And this is the basic bare minimum. So our objectives that are guiding this work as reduction. I think somebody needs to mute their mic. We are accelerating reduction of the burden of communicable conditions. We want to halve and reverse the rising burden of non-communicable diseases. And a lot of that is awareness and information to the population. We want to reduce the burden of violence and injuries, minimize exposure to other health risk factors, provide essential services, and strengthen our collaboration with health-related sectors. So we have strengthened, or we are working towards strengthening our facility-based services, which, as I said, were mainly paper-based and are still really largely paper-based through and this has been, you know, partly realized when we launched the DHIS, which is our health information system, the Kenya Health Information System that provides aggregated data at each facility level. We are not there, but we will get there. Again, the next slide talks about the essential health package. And this just puts emphasis on the need for the reforms at the National Health Insurance Fund, because the UHC is really pegged on a functional national health insurance scheme that is sustainable. And so for us to realize this, NHIF has got to undergo reforms, and particularly in terms of, you know, again, optimizing on technology in their service delivery. It has to be an efficient, strategic purchaser of health services for all the citizens. And work has started and work is going on to realize the aspirations. The other bit that you need to note again as part of UHC is the Kenya Medical Supplies Agency. They are the ones that really are carrying the burden of procuring all health medicines and other health commodities. And really, we are interested to be able to have visibility of all these commodities, you know, from end to end. So, and a lot of partners have been working in this area, and the KEMSA of today is definitely not the KEMSA of 10 years ago. It has I also want to recognize that part of what the government has invested in, the managed equipment service, is really part of what is expected to be you know, to be able to facilitate telemedicine, because the kind of equipment we have bought is, these are very electronically sound equipments that allow for interconnectivity between different facilities, and even for purposes of just reporting and managing the provision of real-time data in terms of utilization and in terms of sharing of data. So we see this working, you know, or we see us achieving the aspirations of the managed equipment service with the work that we are currently doing on HICT. Because when the government invested in this project, it was premised upon telemedicine, so that we could leverage on the very few health workers that we have would be based in the national referral centers providing services to the very remote areas. And we are still moving in that direction. So as an example, today, a radiologist in our National Spinal Injury, and even Kenyatta, can consult a radiographer, say in Garissa and Nyeri. So in some cases, we are seeing, you know, that interconnection fully realized. In fact, just early in the early phases of Corona, I'm sure you saw the minister launching telemedicine conversation between our specialists at Nairobi Hospital and doctors at Wuhan in China. And you know, the doctors were able to talk about management of Corona patients. Again, I mean, an interesting experience, because we also had other healthcare workers from another European countries. So people in 3 different continents connected together and, you know, consulting on such an important issue. So I think I would just say also, I mean, beyond the technology, we must also, for our sector, ensure that we have enough health workers, which is something that we are working on, because for us, having enough health workers means that we are almost assured that we get correct data flowing. Just to put into perspective, sometimes when you go to the dispensaries, what you find is, you know, there's one nurse who is so overloaded with work that by the time evening reaches, she is or he is very tired to input data and send. So for us to ensure that we have got a robustness in our data collection, we are focusing on recruitment, and you have seen that happening in the recent days, because those are plans that were made way ahead of COVID. But of course, we are glad that it is also been timely, because it means that we will have more healthcare workers even as we tackle the challenges of Corona. The technologies in healthcare, I don't need to go much into this. There's all the artificial intelligence and robotics, and it's very good to point out that now we have got some, good, well-trained health informatics healthcare workers who work in the ministry. They have the competency and the capability to appreciate health and technology and make the bridge and bridge the gap, basically. Research and development continues outside of the ministry. There's KEMRI, all leveraging on all manner of softwares and technology. And I think the only thing that we note for us as we move forward, I think having been able to bring to bear to all of you, I hope, the realities or rather the aspirations and the objectives that we have for technology in healthcare. We want to just recognize that in our space, there's a lot of sensitivity on health data records, and those sometimes have an impact on what we can and what we cannot do. So issues of security around our data and storage are so fundamental. And like now, I mean, we've had our data stored in so many different places, even outside of this country. So we are now in the process of trying to bring together our data and getting secure places where it can be stored, and really to protect our healthcare data as a national security issue, away from the practice that we had before. We are very happy to also say that we are working very closely with the Ministry of ICT towards the realization of this. As we speak, there are teams that are out there working to really come up with the solutions that we require for the end user experience at the health facilities. We also recognize that the Data Protection Act of 2019 offers us a platform which then is important in terms of having a legal framework upon which a lot of what we do in health is going to be, based upon. So I hope that I have given you some insight, but in conclusion, I would say that during this time of COVID, I have seen innovations that and just emerging in matter of days than I would ever have realized. I also have been able to appreciate the capabilities that we have as a country, and I want to believe even as a continent, because you find a lot of people coming with innovations around, either managing the contact tracing. We saw ourselves moving very quickly from manual information sharing between labs. We saw ourselves very quickly automating our EOC and having it connected, that is the Emergency Operations Center, and having it connected to the call center at Safaricom. I mean, we have seen overnight getting dashboards that are able to help me where I sit, and anyone in leadership, what the stock levels are for the lab commodities and reagents, and the way in which these things have emerged and continue to emerge, because every day you get people who want to offer something that will help us be, better in our responsiveness and in our public engagement, is just amazing. So for me and for us in the health sector, there is no doubt that technology will play a very central role into the future, and specifically for the realization of the universal health coverage, even way beyond COVID-19. Thank you very much. I am done, Secretary. Thank you.
Thank you, PS. Thank you, PS, for bringing these insights about what the government is doing and also opportunities that the other stakeholders can play. We take now to our moderator, Josephine.
Thank you very much, CEO. I think without much ado, we want to welcome our event moderator to take over from us and therefore lead the next session, which is a panel discussion. So our moderator for today is Dr. Ademola Olajide. And at this point, I want to welcome him to just take over and have the engagement going. Karibu sana, Dr. Ademola.
Hello, can you hear me?
Yes, we can hear you. Welcome. We would also be happy if you could unmute your video so that we can see you.
My video is on mute. My camera is on, as
Now
well as my mic. Can you see me now?
Yes, we can see you.
All right, thank you very much, CEO, the PS, and thank you for that very insightful keynote address. Clearly, as the PS has said in her presentation, the world is experiencing an unprecedented challenge, a challenge that certain parts of the world, if not the entire global community, were not exactly prepared for. And this brings me back a little while. In 2011, very early 2011, February to be specific, I resumed as the head of division for health, nutrition, and population of the African Union Commission. And one of the initiatives the African Union had at that time was telemedicine. The African Union was looking at how we could quickly on the continent expand capacity to utilize technology to support healthcare service delivery. But the challenges were enormous. The adoption was slow. Interoperability of equipment between different countries and different projects was limited. Essentially, Africa had what we at that time called pilotitis. It was riddled with a range of pilot initiatives, and the capacity to take them to scale became a serious challenge. Now, fast forward 2020, we're faced with the COVID pandemic, which has imposed upon us new ways of doing things. As we heard from the PS, we've had to adopt new ways of running our healthcare delivery system. We've actually had to rethink, in some cases, what we define as our healthcare delivery system. We have seen communities climbs where we thought they had strong healthcare delivery systems, but then people started dying in the tens of thousands. And so we have to interrogate what we mean by strong and what we need to be able to put these systems together. The COVID pandemic imposes upon us an urgency for us to move very quickly. Because going forward, we are going to be constrained by the fact that we must maintain physical distance. I'm not an advocate of social distance. Physical distance should be the norm, and technology should be used for us to continue to have social interaction. We must be able to reorganize our work, particularly with the healthcare sector, just as the PS had very aptly described, so that resources are free, resources are efficiently put together, and efficiency is gained. And we must also be able to use it to manage information, to manage evidence, to do a range of things. Essentially, in responding to COVID and post-COVID, one thing is clear: it will not and cannot be business as usual. So for me, I'm going to put on the table 4 quick points, and I will go to our panelists, hoping that we can also have very brief highlight and points that can have an insightful conversation. First thing, ultimately, this is about delivering health, that state of well-being, and health must be a product and must be the product. Okay. And if health is the product, the people must own the product. They must own the response. We must be able to enable communities, homes, and individuals, irrespective of their social status, to be able to leverage whatever innovation that helps them deliver health. Therefore, we must democratize the process as much as possible. Secondly, we must avoid the output and the process being commodity. It cannot be commoditized, such that some people will not be able to afford. It must be such that it becomes a bridge of inequality. Innovation is not negotiable. We have to do things differently. And of course, technology would remain a critical tool and an enabler for us to be able to do that, while it remains a key component of that ecosystem. It must function effectively within an overall ecosystem, and that has been the challenge that we have seen today. People have come up with brilliant ideas, but they have not been adequately integrated into the larger ecosystem to ensure at the end of the day we're efficient and we produce health. So it's going to be my pleasure again to invite panelists to begin to intervene in these areas and tell us what is possible, what is feasible, what are the issues that we need to take into consideration going forward. And it's again my pleasure to invite the CEO, who will intervene with regards to digital health possibility. Engineer Tanwe?
It just looks like this. You only see one side. I see three. Go like this.
CEO?
Yes. On the moderator, I think you need to bring in the CEOs in the panel.
Okay, so that is fine then. Then I will move to Dr. Charles Kamutho, who is the CEO founder, Daktari Africa, and he will be able to respond to some of these things we have raised, particularly on the role of telemedicine, teleconsultation, and building on the experiences they have. Dr. Kamutho, you have the floor.
Thank you very much. Thank you very much, Mr. Olajide. It is indeed my pleasure to be here with you all. Thank you to the organizers. Thank you, Stella. Thank you, Josephine. Thank you to everyone who has tuned in. And as indeed has been mentioned, my name is Dr. Charles Kamutho, and I am a consultant physician and the founder and CEO of Daktari Africa. Daktari Africa is a telemedicine platform which connects patients and doctors by audio-visual teleconsultation. Our platform carries out various functions. It has an electronic health record and enables even education of both parties, both the patients and the care providers. I do have a presentation, so if the Secretariat would be kind enough to put it up, I could share that with you.
Hello, Dr. Charles. Perhaps
Yes.
you could start presenting. We will have the presentation on shortly.
Fine, in which case I may just assist you by sharing my screen, if that's okay.
Fantastic. That is also okay.
Okay, let's do that. Let's just go there, 1 second. So basically, even as I get this ready, the whole idea of Daktari Africa, as I said, is to focus on the most important aspect, in my view, of what healthcare is all about. Having practiced for some time, I have concluded and had the pleasure of getting this confirmed from my colleagues and patients, that the most important aspect in healthcare is the relationship, the trusting professional relationship between the caregiver and the patient. So that relationship, that very delicate communication between those two individuals is the essence of healthcare. And everything around it, which is very important, just goes to enhance that relationship, that provision of service. So you have the patient on one side who comes in with a need, a health need, and you have the expert on the other side. And that expert is able to provide the service only if the patient trusts that doctor. Trust for us is very key. You know very well how important it is to go to someone whom you know and you trust because of their caliber, because of the education, the training, and you immediately, in some cases, I've had experiences where I've seen senior colleagues of mine who, when patients arrive, the patient already feels better because they know they're in the presence of someone who knows their stuff and who cares for them and is able to treat them well. So everything else that goes around that, the diagnostics, the payment systems, the infrastructure, be it the hospitals, etc., all that is actually peripheral. And if we want to strengthen healthcare, we must focus on access between patients and care providers. If I'll just go to my screen, if you'll give me a minute. Here we are. I hope you can see that.
Yes, we can. Please go
Thank you.
ahead.
Okay.
So our target, our aim is essentially to make people healthy. We focus on that. And for us, what patients want and what the country needs is a healthy population. We believe that there is no wealth. We're talking of Konza, we're talking of economics, which is fantastic. And I like the whole concept of this conference. We believe that for there to be wealth, economic wealth, we need healthy people. We need many people, we need educated people, but they have to be healthy. Otherwise, we are back to square one. And we use technology as Daktari Africa to make that healthcare easier for people. I started Daktari Africa in 2008 as an online community of doctors. The whole idea was to build a digital hospital, which is what we are. And right now we have over 500 doctors who have already signed up to this hospital. And the whole idea, we started very small. I remember I started with just 6 doctor friends of mine. And I told them about the idea back in 2008. I came up with a website. I got my IT friends to come up with it. And they all signed up. And we built up until over 500 to date. Having that pool of doctors, then it made sense to get patients who could also join and learn from those doctors because of the educative material that the doctors were providing on daktariafrica.com. They could share their health data because we enabled patients to be able to keep an online electronic medical record securely, password protected, HIPAA compliant, in such a way that they could keep a record of their blood pressure, keep a record of their blood sugar, and they could share this information with their doctors, the doctor of their choice. So we enabled the patients to have access and control of their own data. For us, that was key because I had seen the environment in various countries that I had worked in or trained in. I have seen the environment in the US where you have silos of information. Similarly, in the UK, in Australia and Japan, they have different systems which are also working very well. And of course, here in Kenya, we were the first patient-centered telemedicine platform back in 2008. There had been other systems of telemedicine which were doctor to doctor, such as the one which was started in the early 2000s between, for example, Kenyatta Hospital and Machakos District Hospital. That was actually sorry, a bit of noise in the background, Secretariat. So, so the first telemedicine platform, or among the first, was that one between Kenyatta Hospital and Machakos. But I believe the very first one, indeed, was between Coast General Hospital and Malindi Hospital. That was actually the very, very first. But we are the first patient-centered telemedicine platform, meaning that a patient could consult a doctor directly. So as I was saying, and as is shown on this slide, we created that online community of doctors where patients could come, and now we have over 10,000 patients who have already signed up, and they're able to access various services on our platform. At that time, in 2008, I was actually working as a consultant physician at Thika District Hospital. And I was very glad to hear PS Mochache describing how the healthcare workers work so hard. And sometimes, you know, we look back at the end of the day and we wonder, number one, do we have time for either entry of data? Do we have time to do anything else? Sometimes it can be really, really, really difficult for our colleagues in the public healthcare system because there are so few. And because our system of public healthcare is so trusted by our Kenyans that they all come to the public health facilities. They don't go to, you know, the miti shambas, not as many. They don't necessarily go to other alternative methods. We know they do some of them, but what I'm getting at is that there's a large trust already in the public health system. Our challenge really is not developing trust among people, it is availing doctors. And we know, for example, in the public health system, like when I was even there in 2008, we were very, very few physicians. And fortunately, that has changed. So we are now more doctors now. So sure enough, what led me to start this? And I think this is important. What led me to start Daktari Africa is the experience of dealing with many people, many of them very young, who were developing conditions, lifestyle conditions, which we call non-communicable diseases. And those diseases were hampering their development, or were hampering their growth as professionals. There were many young people I saw developing high blood pressure. Others developed, diabetes. And because of the inadequacies of the system, and because of their traveling, sometimes they would travel to different parts of the country and they would not be able to come back as soon as they were supposed to. So we'd give them an appointment for 3 months or 6 months. But unfortunately, because they were posted for work reasons or family reasons to other places, they would come back a year, 2 years later. And as a result of that, they were off their medication. They did not even know what their blood pressures or blood sugars were. And by the time they came for the second or third visit, their kidneys were gone. They needed dialysis, or they were coming into the stroke, or they were coming into the heart attack. And I'm talking about people not just in their 50s, but over the time I spent there, because I was there from 2004 in Thika until 2012, I saw the ages becoming younger and younger. So by the time I left, I was seeing people in their 40s coming with stroke, people in their 30s with kidney failure. And of course, then all these were being channeled to dialysis. And in my mind, I asked myself, we're talking of economics here. I asked myself, where are we going to as a country if our most productive people, these young people, are ending up sick with non-reversible conditions, at least at that time? Where were we going to if a young man of 40 had a stroke and could not work anymore? That is what led me to look around and to ask myself, how can we change what we do and how we do it? How can we be more effective in keeping patient records so that wherever the patient went to, their records were available? The patient knew which doctor to visit, and he could actually go there and be seen, and the care could continue. And I recall that's why I named the very first version of the website as findadoctor.co.ke, so that wherever patients went, they would be able to go to the website, find out which physician there is in that town, and go and visit that doctor so that the care could continue. 4 years later, we were awarded with an ICT Vision 2030 award from the ICT board. That was a big injection in the arm, a big shot in the arm, as they say. It was a big encouragement because it told us we were onto something. We got support from an American group called Spring Accelerator in 2018. And in 2016, we won a National Innovation Award from the Kenya Innovation Agency. For us, this was a confirmation that Kenya recognized what the value of telemedicine was. And sure enough, KPMG recognized us in 2017 as a possible solution to the health insurance industry. As I show you in a slide or two, the health insurance industry is actually a very sick one. The health insurance industry is making losses, and in a very large way. And now we are in the point of growth and innovation even further. So briefly, Daktari Africa is very proactive. We distinguish ourselves by being proactive, by being preventive, and by focusing on quality. And as a result, we save time and we are very cost efficient. This slide speaks for itself. One problem we are grappling with, even with COVID, and because of COVID, are the non-communicable diseases. I have already alluded to them, but data from the Ministry of Health shows that half of our hospital beds are occupied by NCDs, patients with NCDs. We're talking of high blood pressure, we're talking of diabetes, we're talking of cancer, we're talking of chronic obstructive pulmonary disease. Those are what we call lifestyle diseases or non-communicable diseases. And over half of the deaths in hospital have been due to these illnesses. And as you are aware, patients with these illnesses are even more vulnerable to the COVID-19 epidemic. So the COVID disease, the coronavirus disease, affects patients with NCDs even more. And if we did an analysis of those patients who are succumbing to this virus, because we know it is just a viral infection which we can overcome if our immunity is good. But those patients with non-communicable diseases are more vulnerable, and they constitute the largest proportion of those who are dying.
You have 2 minutes, please.
2 minutes, thank you. So basically, I just want to mention once again that 21% of our Kenyans are hypertensive. That's 1 in 5, and that's a very, very high percentage. And these complications, again, most of the people do not know that they are unwell. That is what leads to dialysis and all the other complications. Mental health at the workplace is another major problem. We know very well how there are many people succumbing, shall I say, to mental health issues, and this is something we have looked at. The health insurance industry, as I mentioned, is making losses, and this is a slide that shows what is happening in the private sector, but it could also reflect, perhaps, what is happening in NHIF. So the top part of the slide shows how the premiums have doubled from 2013 to 2018, from 20 billion to 40 billion. Yet the losses have been increasing. And this is explained by what I've just shown above. So Daktari Africa has various services. We have all those doctors, over 500, who are doctors, and we include specialists as well. We enable video consultations. So it's not just, some people, when they hear telemedicine, they think it's telephone. We enable also video consultations. We enable electronic electronic prescriptions, and also electronic health records, which can be shared. This slide is important because it shows what telemedicine is all about. We can begin by saying that telemedicine is a part of telehealth, which is a part of e-health. And e-health is everything that includes electronic processing of information. So anyone, even the insurance companies that are involved with this, also take part in e-health. Telehealth includes even things like education and health promotion, whereas telemedicine is more of the clinical services that we provide. This slide, which I'm just coming to the end of my presentation, shows the various models that we have as Daktari Africa. So we provide counseling in schools. We realize that our youth are our wealth. And you all know that, you should know that by the year 2030, most of the youth of the world will be in Africa. And therefore, we want to help to curb NCDs right from the school. We want to ensure fantastic mental health. We want to breed champions right from an early age. We also look at people at the workplace. This is the bottom left part. We recognize that there are a lot of people at the workplace who suffer from NCDs quietly, despite having access to care, but they have simply no time. So we last year developed a very successful program at one of the corporates, working together with one of the insurance companies called Purchase Insurance. We worked at Strathmore School, and we were able to attend to patients, to the teachers, the staff of the school, right from the workplace. So they did not need to leave either for consultations or for labs or for medication. We provided everything to them there. Going back to the school model, we piloted this in 2016 very successfully in 2 slums, in Mokoro Fuatanyayo and in Kibera in 2016, thanks to one of the support groups. This is very relevant now, especially with the COVID, because this is focused, our home model is focused on delivery of care to people in the counties and at home. So last year, once again, last year was busy. Last year, we looked at Muranga County and developed from January to November a telemedicine platform that worked. We were able to see on a weekly basis diabetes and hypertension patients in one of the sub-county hospitals called Nyakianga. And on a weekly basis, we saw patients there who had been seen by the local clinical officers, and we were able to provide higher level service. And we worked very closely with the local nurses and the community health workers. In 2016,
begin to round up, sir.
Thank you. Yes, 2016, we modeled something with the pharmacies. And this is just a brief recognition of our work. We have won some awards, and very importantly, and this is my second last slide, actually my last one, we are approved by the Medical Board and the Pharmacy and Poisons Board actually from 2016. So thank you very much, and I'm glad to answer any questions that may come.
Thank you very much, sir. It's been a very interesting and insightful presentation. So that we also move on time, I would invite Mr. Thomas Kisimbi to take 5 minutes as well to intervene so we can have time to interrogate these very brilliant presentations. Mr. Kisimbi, the managing partner at Aspen Management Partnership for Health. You have the floor, sir. Is Mr. Kisimbi with us? Okay.
Dr. Demola, Mr. Kisimbi has dropped off because of power issues. He's trying to log on. Maybe we can move on to the next panelist as we wait for Dr. Kisimbi to get back on.
All right, that's fine. So we'll go to my friend, Mr. Alfred Obengo, the president of the National Nurses Association of Kenya. Nurses are frontline staff. They remain very critical to providing healthcare services across the continent. How does this sit with you and the members of your association? Mr. Obengo, are you on?
Okay, I'll be speaking on behalf of Mr. Alfred Obengo. So all right, thank you very much. I'll give a brief introduction. My name is Jemima Nyawera. I'm the Programs Officer at the National Nurses Association of Kenya. And to quickly go to the topic that was given for the association, how technology is empowering the frontline staff in the face of the pandemic. First of all, to begin with, when you're dealing with any pandemic, you need a very skilled workforce. And the Kenyan healthcare workforce is one workforce that's been privileged to have skilled doctors, skilled nurses, skilled clinical officers. And we've seen the example in terms of their secondment to other African countries like Botswana and Namibia when there was a high prevalence of HIV and AIDS, and the recent cases of Ebola in Liberia and Sierra Leone. Some of the Kenyan healthcare workers were seconded to this country. And these are some of the health care personnel that are actually involved in the current COVID pandemic. So the question is, how have we used technology in Kenya to empower this very critical group of healthcare personnel? Using the example of nurses, through our regulator, that is the Nursing Council of Kenya, we were privileged to have a mobile-based application through the World Continuing Education Alliance that provided COVID-related training resources for nurses. And it's interesting that once we launched this application, we had more than 6,000 nurses accessing it and getting resources that were COVID-related, as compared to the face-to-face trainings that were already being rolled up. So it shows you how technology was really able to scale up the issue of training. And the other good thing is that these trainings were accredited by the Nursing Council of Kenya. They were accredited, and so once you get to do the training, you also earn continuous professional development points. So at the end of the day, it's a win-win for the person taking the course. So that's one way that we've used technology to really empower the frontline staff in this phase of the pandemic. The other one that I like to mention through Konza, through Madam Stella and her team, we are piloting a communication system to support the frontline healthcare personnel during this pandemic, whereby it's called a push-to-talk service. And as long as you have a mobile phone and using very little internet, we want it to be a platform whereby healthcare personnel can call in and receive counseling. It is good to mention that during this pandemic, we have had our healthcare personnel being stigmatized, not only at their workplace, but even at home. And this is not to blame the people stigmatizing them. Everybody has been, COVID has scared everybody. So the person dealing with the patients have also received some form of stigma. And in a way, it has impacted their psychological well-being. And even beyond COVID, we have a lot of other psychosocial issues that healthcare personnel face. So through this app that is called Air Systems, we successfully did a dry run on Friday. And the idea is to create a platform where a healthcare worker, even in Turkana, can consult with another healthcare personnel in Kwale, probably at this phase, we're looking at having a list of trained counselors that can provide that kind of care to them. So that's another way that technology is really coming on board in terms of dealing with a pandemic. The other good thing is that this platform is also enables you to register an emergency, and we're able to pick up your emergency as per your location. So if the command center is at the national center, somebody in Samburu, for instance, is able to call in and we receive the emergency and we are able to dispatch that particular emergency to the relevant bodies. So this is how technology is really supporting the frontline healthcare workers to deal with this pandemic. The other thing, as I quickly finish, I have to say that this was a short notice, so I didn't have a PowerPoint presentation, but I like what the PS alluded to at the beginning about security of data in terms of how do you protect the security of health data, because we deal with very sensitive personal issues for people, and you want to make sure that this is protected in a way that your client's data is not exposed in a way, and it is a national security agenda. So probably from these discussions that we are having, and they're very enriching, one discussion that that I believe most of us in this forum will agree with is we do have a lot of sharing of information on WhatsApp. It might not be a very appropriate media for communication, but it is happening and it helps a lot of people. You could call it a form of telemedicine, because we do get, we consult amongst each other. Even during this pandemic, you get someone asking you, what should I do here? I have this patient, blah, blah, blah. So being able to create a platform, a Kenyan-based platform, because again, we also, Dr. Olajide, you alluded to the fact that there was a lot of pilotitis, you called it at the beginning. How then do we move beyond piloting to having our own local-based solutions that can scale up the issues of telemedicine? We've seen a lot of webinars that have been organized whereby people are discussing case management for COVID, how to support the psychological welfare of both healthcare personnel and even the patients that they're taking care of. So the issue I'm bringing here is about how can we, through the support of partners like COTDA, how do we create a platform where we can have doctors and nurses, other healthcare personnel consulting on matters health, and people are able to share this on real time and get a lot of information. So yes, so I think I will not go beyond there so that I give the other panelists an opportunity. Thank you very much.
Thank you very much, Dan. That's an appropriate place to actually transit to the next panelist, but then you have been able to raise very critical points and provide us very practical inputs, despite not having a PowerPoint, and it has been straight to the point. So I would move quickly to the CEO, co-founder of Ilara Health, Emilian Popa. Are you on? Provide us your insight.
Yes, hi. Sure.
Thank you very much. 5 minutes, let's do this.
So the insights I'll give you, so I've been an investor and an entrepreneur in Africa for the past 10, 12 years. I currently run a healthcare technology company called Ilara Health, where we place diagnostic devices in the peri-urban and rural clinics around Nairobi, around Kisumu. But just my one insight actually, and getting back to the telemedicine and to the presentation earlier of Daktari, which is an amazing, I really, really love the presentation. The challenge that I see, that we see, and I see every day in the clinics in Mbakasi, Kayole, Gitura, Ruiru, is that, where a big chunk of the population lives, is that consultations are actually 0 or 100 or 200 shillings. And in most of those, there are 2,500 small medical centers around Nairobi and another 1,500 around Kisumu. Most of the patients who buy meds in the facilities do not pay for the consultation. As much as I love telemedicine and there is a massive need, I found very difficult to see the monetization around telemedicine. So how do you really can charge patients when patients in those areas, in the mid to low income areas, do not pay for consultations. And I've been in a lot of discussions recently with peers, investors, also entrepreneurs, who have seen an opportunity even bigger today for telemedicine, right? Where patients stay home, where medical facilities have no idea what to do with patients coming with a fever or a cough because they think that they have COVID. And we've seen actually a lot of medical facilities that are closing down or halving the number of patients they receive because they don't have procedures in place. So we see actually an increase in the demand for consultations at home, for consultations over the phone or over video, but I haven't yet found, through discussions with peers, a way to properly monetize those consultations in mid to low income settings. As much as a consultation in Nairobi at Medanta or at Nairobi Hospital or somewhere else, will be paid 1,000 shillings or 1,500, but in the mid to low incomes there are close to free. So that's kind of my insight on telemedicine, and I wish there was a simple answer to this. What I've seen actually in other markets where telemedicine has been trying to take off is actually a mix of plugging telemedicine, so plugging consultations in with other services such as delivery of medication. So companies trying to build telemedicine solutions, they look at the service not only as a consultation, which may be a loss leader, but as a mix of consultation plus, like in a primary healthcare, consultations plus meds plus diagnostics. We plug this together, we bundle this together, and you may want to monetize one, but keep the other one close to free.
Thank you very much. Those are very critical insights, because indeed, if we're not able to find a way to get resources from the services we provide, then sustainability becomes a challenge. It then becomes a great idea that cannot grow to scale. And that has remained part of the challenges that we continue to face. So I would move on right now, and thank you for that, to Ms. Kathleen Dolcott, who is the CEO, co-founder of FLAIR Emergency Response. Is Kathleen on?
Yes, I am. Thank you.
Thank you. So please, 5 minutes, straight to the point. Thank you.
Yeah, of course. Good afternoon, everyone. My name is Caitlin Dolcott, and I am the founder of FLAIR. So FLAIR started 4 years ago with the bold but definitely difficult vision to ensure that every single Kenyan has access to emergency services. When we started, the average response time to get an ambulance in Nairobi alone was over 3 hours. You can do anything in 3 hours. And in an emergency situation, oftentimes it's a difference of seconds or minutes that can, save an individual's life. And so when we started the company, we said there had to be a way to be able to deliver rapid, effective emergency response in minutes, not hours, not just in Nairobi, but throughout the country. Every single day, there are thousands of emergencies that happen, whether it's maternity, whether it's road accidents, whether it's cardiac, or today, whether it's COVID-related emergencies. And so what we have done over the last several years is to assemble all of the different ambulance companies onto one central system. So the opportunity that we saw was that there actually wasn't a lack of ambulances.
Yeah, today's Wednesday.
Sorry, please go on.
Okay. We realized that there was actually no lack of ambulances, that there's hundreds of ambulances that exist throughout the country. What lacked was a centralized way to be able to access those services. That there was plenty of trained emergency technicians, EMTs within the health system, as well as nurses that could staff and operate ambulances. And so what today we operate is the largest network of ambulances. We operate through the entire country, over 500 ambulances. And these are all from, leading healthcare providers, both government as well as private ambulances. And so that means that we have finally the scale to be able to create a functioning 911 or 999 system. We've reduced response times down from hours to minutes, and have been able to, save tens of thousands of lives by getting people quickly to care. So just to kind of transition into like what we're doing for COVID and where we see pre-hospital care essential, given the topic and what we're discussing today, is that there's a few essential ways that ambulances plug into this overall response. Number one is that, there will be individuals who contract COVID and require emergency transport to a hospital. Or there will be patients that require transfers between hospitals, say from Mbagathi to Kenyatta University. An ambulance is really the only safe way to be able to transport a patient. And so it's essential that there is that link. The last thing that you would want is a suspected patient or confirmed patient using a matatu or a taxi or going by their own means to the hospital. So we've already handled dozens upon dozens of cases during COVID under those two scenarios. But I would say the second kind of area, though, that we're seeing is that even more so, when the healthcare system is strained or put under stress of a pandemic, which every single health system globally is right now, you start to see that people are going to the doctor less. There is less primary care, and until we have widespread, for example, telemedicine that you guys are talking about, people delay care. And so we're actually seeing an increase of emergencies related to, maternal emergencies, women not being able to get to the hospital to deliver. We're seeing a lot of increase in psych cases, mental health. We're seeing increases in anxiety and, other illnesses that, oftentimes, for example, heart attacks that can be brought on by that. So we've been, ensuring that our core services can continue and remain and transporting patients quickly and safely to the hospital. We just launched last night in partnership with Bolt as well as KHF, Wheels for Life, which is a free service offered to women in Nairobi for during the curfew hours to be able to get to the hospital. So either a taxi will be sent if it's a low kind of acuity or low urgency case, or we will send an ambulance from our system. So I'll stop there, but I guess in short, just the last thing is that pre-hospital care is really the conduit to care, is that you need to be able to access services. And oftentimes, those services need to be accessed through ambulance. And so that is the kind of key role that we play, is making sure that we can connect all the dots in the healthcare system, because while ICU beds might exist or certain facilities have the capacity to treat patients, unless there is a means to get to those facilities, patients are stranded or not able to actually receive the care. So thank you so much for having me today, and really appreciated learning and hearing everyone else kind of discuss the ongoing initiatives, because I do think like now is the time to use technology, and I think we're in a really, really good spot in Kenya because of kind of the adoption and the success that many other technology has taken off. So I'm really excited, despite everything happening right now and the craziness of trying to run a company in a pandemic, I am actually quite excited by the opportunities in front of us to really make a change in the healthcare system.
Thank you very much. And thank you for the insights you have provided and the critical importance of connecting the dots like you have presented it. And it's a very nice place to also transit to listening to the Kenyan Medical Association. We've got the president online, Dr. Gital Maina. Are you here? It would be great to get your insights, Dr. Reed. Dr. Gital Maina? Okay. While she's trying to join us, I would also then invite the Vice President of Operations, Elephant Healthcare, and that should be Mr. Michael Dowling. Can you provide us your insights?
Yeah, sure. Hello.
Thank you very much. 5 minutes, and let us also learn from you. Thank you for taking the time to join us.
Absolutely. Yeah, thank you all for having me. It's a real honor and pleasure to be here. I might share my screen as well, rather to share a couple of slides. So I'll just do that. But while that's loading, I'm representing today a company called Elephant Healthcare. And our mission is essentially to use technology to make healthcare better for everybody. And we take an approach that's all about connecting people, connecting information, and all of the different parts of the healthcare system together. And with the objective of helping countries like Kenya to achieve universal health coverage. And we're a company based predominantly in Kenya and also in the UK and London, which is where our founders are from, both doctors from the UK's National Health Service, who sort of saw this challenge and said, how can we take simple technology and use it to enable universal health coverages in other countries based on the model that we have in the UK. We've been partnering for the last year with counties. There's a small diagram here for those of you that can see across the country. We're now partnered with 12 different public health systems across Kenya to provide our digital solutions. And I'm going to tell you about two of those very briefly, about 45 seconds each, to provide some context. So the first product that we're working across the country with is what we call our operating system for universal health coverage. It's essentially a cloud-based mobile health management information system where all of the doctors in the clinics that we work with get a simple tablet that allows, and the registration clerks and the lab techs, that allows them to manage their patients, for patients to have a medical record that they can take away with them, that they can access on their mobile phone. It allows management of stock. The Principal Secretary was talking about the importance of medical supplies and KEMSA and being able to track drugs from delivery right down into patients' hands. And the pharmacist, by dispensing drugs to individual patients, allows that kind of level of tracking. Billing and insurance, it links up the billing system. We were talking earlier about the importance of connectivity and integration of all of the different systems within healthcare. How do you know what someone has had, what's been paid, and allowing this sort of essential health package that the Permanent Secretary was talking about to be made affordable by knowing what are the different costs that build up for each individual patient. And then finally, pulling all of that information together into dashboards that make that allow decision making. And with the kind permission of Kisii County, I'll just show one dashboard, which is from one of the facilities that we're partnered with in Kisii. And you can see here, there's sort of live tracking of IDSR cases. You can see the very last case of typhoid was reported for a 51-year-old a few days ago. You can see registration. They can see registrations by day. They can see consultations by day. This is this drop-off in access to care that Kathleen was just talking about. So you can see very, very clearly how people have stopped attending this particular clinic, and you see that across all of the clinics that we're partnered with. The breakdown of diagnoses and live from the ministry, they're able to sort of manage and see this information and use that to make decisions. This was all going wonderfully, and then it comes up the question, okay, so what happens when COVID arrived, and what's our offer for COVID? And we said, well, what would happen if we could connect a whole county or a whole country in 24 hours? And we launched a product last week, which actually allows every single health facility in a county to be connected to the central ministry. They will receive, if every facility receives an SMS message once a day asking for a very, very short general update with a set of questions. We're also able to do that with the community health volunteers in order to bring the sort of care and monitoring and support to the very, very front line, to the level one sort of part of healthcare, which again, we were talking about earlier, the importance of that, especially as people aren't leaving their homes and as we need to take care to vulnerable people in rural communities. And again, in the spirit of staying nice and brief, with the kind courtesy of Bomet County, I'll just show you one dashboard, which is the dashboard that they're using with yesterday's data. So you can see here for the total suspected COVID cases that were reported. They've fortunately had no confirmed cases. The number of clinics and the number that are open, their health worker availability is still doing very well at 96%. We know this comes down over time as workers get sick. We've seen that in the UK and in other countries. And then it's facility by facility. What's the status of essential medications? What's the status of their emergency trolley? where are they out of stock, what's the status of bed occupancy, where is full, PPE by facility, and again, the phone numbers of all of the in-charges. So if there are any issues, they can be contacted. And of course, a sort of comment section where they're getting live two-way communication with the different dispensaries, asking for help or support, or being able to provide sort of bespoke updates when things are needed. And so I'll conclude there, but I think the summary is there is some amazing simple technology available that we can use to take I couldn't agree more with what Dr. Kamoto was saying. The most important thing in healthcare is that relationship between the caregiver and the patient. How do we allow caregivers to have the maximum time focusing on patients, and to have very, very simple tools they can need to make sure that their needs met and they're backed up with all of the things that they need from the health system to be able to offer that care. And we're going at that from a public sector angle by partnering with public health systems across the country, and ready and excited to continue to do more.
Thank you very much, Mr. Dowling. This has been quite interesting to see, and to see that counties are already adopting it also provides us the hope that we can then thoroughly integrate this, interrogate, and take to scale. Is Dr. Gital Maina back with us, the president of the Medical Association, to provide our insights? While we're still waiting for her to speak to us, we can check to see if Mr. Thomas Kisimbi is back online. Mr. Kisimbi? Okay, we've listened to quite a range of interventions. We've listened to quite a range of innovative approaches, all aimed at ensuring that at the end of the day, decision makers are able to make decisions, clients are able to access services, and health workers are able to function in a much more efficient manner. In Kenya, we do know that healthcare is devolved, and therefore counties also have a very important role to play in terms of providing healthcare services and guaranteeing the health of citizens. So it'll be an opportunity for us to have people representing the counties, the county economic block CEOs, to kindly also weigh in and provide some perspectives. I would also encourage participants to ask their questions in the chat box for us to curate that and provide to our panelists, as well as putting all this together so we can collectively, going forward, also look for answers to this and see how we can take it forward. Also, we're encouraged to tweet. It's #InnovateHealth. That would be very helpful. And so if Ms. Faith Mutoki is online, the CEO of the Southeast Kenya Economic Bloc, it will be nice to have her views at this point. Ms. Faith Mutoki, is she on? As we're waiting to see if she's on, we can also seamlessly move forward to see if Dr. Dominic Biwott is on. He's the CEO of the North Rift Economic Bloc. To have the CEOs of the economic blocks also intervene. We've listened to various perspectives. Okay, do we have Honorable Guled from the Frontier Counties Development Council? Any of the CEOs, Mr. Kodek Umwancha or Mr. Gachunia, the CEO of the Central Region Economic Bloc? If any of the CEOs are on, they can feel free to intervene at any point. What we've found and we've listened to is a range of brilliant, innovative approaches that allow us to address the issues of healthcare service delivery. Essentially, okay, so Dr. Gitao Maina, please, we didn't hear you. Can you come on? Please feel free to intervene if you're on. Do we have questions? So we can also provide that to the panelists.
Yes, Dr. Demola?
Yes.
Josephine here. I'm looking at the question and I can see a few of them coming in.
Okay, so then go on and present them. Flag the questions.
Okay, so I'm presenting a question, I think from the group. I think this is actually one of the questions that came in from the RSVPs, and it says that what are the key factors investors need to look at before taking up an idea or an innovation, and what is supposed to be the idea share ratio? I think this is addressed to the founders of different medical companies, and one of them can support as I look at the next question.
Okay, can Ms. Dolkat try to take that for us? Kathleen, can you try to take a stab at that? If not, we can also ask Michael to try to provide an answer to that. There's also a question that says, how are innovators supposed to use the information we've been provided? So Michael, can you try, or Kathleen, or any of the CEOs for that matter?
Kathleen, you want to go? Otherwise, I'm happy to.
Yeah, you go ahead and I'll fill in.
Okay.
All right,
sure.
great.
So go for it. I mean, I think in developing any kinds of products, there is this like tension between innovation and trying new things, and also just establishing and sort of following through on existing ideas and making the ideas that already exist available to more and more people. So many of you will have heard of the concept of like agile development in technology. And I think at Elephant, the way we try and think about this is just have this constant flow of ideas with our customers. And so for us, it's all about finding partners, whether with a specific problem to solve, taking the product that we have, and then beginning with that, and then over time iterating and changing and working together with like specific partners to solve specific problems, rather than building too many things in abstract. So that's the way we think about it.
Thank you. Kathleen, you want to fill in?
Yeah, no, I would just second that. We also use agile development because the problems that we're trying to solve are so massive that it can also feel very overwhelming if you're trying to do too much or develop too much at once. I guess on the investor question, because that was your first question, correct?
Yes, that's the first question. Please go on.
Yeah, so as it relates to like what makes something investable, I mean, there are investors at every single stage of the continuum of starting a company. So when we initially were funded, we had nothing more than a concept on a deck and an idea. So I mean, I think it is about matching who you're trying to raise money from. So obviously we would not have been able to raise from traditional kind of investors or banks or been able to access that type of capital. So in our earliest round, we raised from angel investors. We actually raised from a number of physicians in Kenya to be able to build the first prototype. Today we raise from venture capital as well as PE because we're at a different scale. So I would just say that for every single point in the process, there are investors that do finance projects, and just making sure that you're targeting your right set to be able to lift off.
Maybe, Chairman, I could just add on to that. This is Dr.
Please
Kamoto.
do, Dr. Kamoto. Please do.
Thank you. Our experience at Daktari Africa has been very interesting over the years. Just to mention that with healthcare innovations, with telemedicine innovations, the focus for us, our focus has been health outcomes. We have been focused on getting people better. The tricky thing about investments is that they focus on return. What profits, what returns, what percentage increase in investment, what return on investment can one get from putting their capital in there? Just to reiterate that we focus mainly on good, better health outcomes in the people we look after. Our belief as healthcare providers is that if the healthcare improves, if the relationships with the patients improve, the returns, the monetary returns will follow by default, and they'll follow in large amounts. So for us, our focus has been on the primary clinical outcomes, knowing that, as I said, this will lead to monetary returns as well, which we have already seen. When we started in 2008, it was mainly from friends and family. The friends and family were the ones who were investing in our company. In 2016, we got our first angel investor who made 2 rounds of investment. And in this year, 2020, we got our first, modest investment from a VC, which we could call as a round 1 investment. But just as a word of caution, that the returns in healthcare are not immediate. They're not immediate because it's not a healthcare, it's not a commodity that you're just selling off the shelf. This is something that takes time, and fortunately, our VC partner has recognized this. We, as in the course of our development, we focused on what we call human-centered design. So we had a first version 1 in 2008, which we reiterated in 2014, and we're just about to launch version 3.0, which should be coming out later this year. So there's constant, use of a model. We go out to the public, we learn about the usage of that model with the public, with the various stakeholders of the ecosystem, because the technology is, I like saying that telemedicine is not a medicine in itself. It's not that you put in the technology and everything works. Technology is one more tool in the doctor's bag. So it has to encompass, it has to be part of the whole ecosystem. One has to think, what is the patient looking for? What are the pain points of the patient? What does the doctor need to work efficiently, safely, to be able to share information if needed? What do the various authorities, be it government, be it the insurances, what information do they need to design policy to effect payment systems? So we were talking about NHIS, and I like the comment of the question actually that Emilian raised about the sustainability of telemedicine platforms and other innovations. If we look at the actual situation, we find that people pay very, very little, especially in the public sector. And the question that as an innovator one should ask oneself, or as an investor, how does one make returns? So our answer to that as Daktari Africa is actually the answer that the PS mentioned, PS Pochache. That is actually a question of universal healthcare. I'll elaborate this in a minute. If we can get to a situation where patients realize that by becoming members of NHIF, they have access to proper care, then more people will pay for that membership of NHIF. If they're able to, by virtue of that membership, have access to a doctor, have access to tests, have access to medicines, because that's the pyramid of healthcare. So consultations, diagnostics, therapeutics. If by being a member of NHIF, they have access to those services, they will join NHIF in droves because it's of value to them. It just makes sense. And therefore, this is the missing link, I would dare say, between NHIF and provision of services, and this is the opportunity that telemedicine provides by having those partnerships with NHIF and other insurance companies. Thank you.
I just want to add a quick one on top of this. So you're totally right. I think from an investability point of view, and I want to add here kind of both an entrepreneur and as an investor hat. From an investability point of view, because we all are in this, we try to make an economic model out of a public good, which is healthcare, which in other countries is financed by the government, right? And it's not easy. As you said previously. So from an investability point of view, it's I always look at a market. How big is really the market that we tap into? How many people are there in the market we address? And unfortunately, I think most of the easily monetizable models in healthcare tap into the upper income population. But I think most of us are actually into mid to low income population, and those are the main, most of the people in our markets in Kenya. So how can we really make money out of it? How big is the market? And what's kind of the future of this? How is it growing? And this applies to anything, to telemedicine, to diagnostics as we do, to ambulances. So I think that's the conversation that we on our side have with investors every day are around really the how big this can be, and can we really bring value to our stakeholders and shareholders in the future.
Thank you very much. I think a lot of issues have been flagged, And these issues are very critical when it comes to expanding, scaling up on innovation. It's also important because some people have raised the question about the enabling environment. You've touched on it with regards to issues of investment, with regards to the kind of financial vehicles, the models, trying to build a profitable venture for what is a public good. At that time when the African Union was implementing what it called Pharmaceutical Manufacturing Plan for Africa, one thing then became clear, that the kind of financial products that financing institutions on the continent were offering were not adaptable to the pharmaceutical market. It was adaptable to the other commodities, but not pharmaceuticals, for the very reasons that you have all highlighted, because again, it goes to health, which is a social good. And so going forward, I would think that one of the next levels of conversations we have to have around the subject of innovation is looking at all these questions that relate to enabling environment, that relate to investment, that relate to connecting all of those dots and skipping the obstacles in such a way that while responding to COVID, the post-COVID era will be such that we can go to scale and young investors can also get an opportunity for them to play. And government would appreciate fully the need to thoroughly invest and support innovation. And innovation can actually expand and grow from Kenya across the African continent, where we still have about 1.3 billion people who are yearning for an opportunity to access services. So at this point, I'd like to thank all of the panelists, thank those who have asked questions, and hand over again to the Konza Technopolis organizers. And thank you very much for giving me the opportunity to moderate this, and I look forward to us taking this conversation forward as we move off this platform.
Okay, so thank you, Dr. Ademola. We have had a bit of challenge with the connection with Dr. Gitau. She's in, but we are not able to hear her. We also had a bit of challenge with the CEO for the coast block who was logged off. I don't know whether he was able to log back in. Maybe we can give him 3 minutes. Mr. Emmanuel Nzai. Mr. Nzai? Okay, Dr. Gitau from Kenyan.
Stella, can you hear me?
Yes, I can hear you, Dr. Gitau.
Oh, finally. Yeah, so I think I'll possibly go ahead and just give a few comments from Kenya Medical Association in the interest of time, saying that it's already 4 p.m. and you're supposed to end by 4.
Yes, yes, please.
So, all right. So basically, from the discussion you've had, I was able to listen in a few of the presentations regarding telemedicine and also in terms of patient management. Your question to me was regarding in terms of use of technology in terms of prevention of patients, prevention and also in surveillance. So what has been happening so far in terms of prevention, there's a lot of technology that has been used in terms of pushing prevention messages. If you notice, most of your social media, when it comes to text messaging, there's been a lot that has been sent in terms of prevention. And even when it comes to surveillance in terms of prevention, in terms of mapping out which are the risky areas and where the infections are cropping up. And this is the one which has even made the government make the decision it has made based on which areas do you close off, why do you close off Nairobi and Mombasa and all, and use of even phone data. We have been able even to, the government has been able to use phone data to be able to contact trace for people who've been in contact with other people. They have used this to follow up patients, certain patients who have had their tests done and they've moved countries, and government has been able to get them through that. So of course, there's been a lot that technology has helped in terms of the war against COVID when it comes especially to surveillance. When it comes to basically health workers, so what's in terms of technology, what has happened with health workers, most of the medical education usually happens offline. You go to a hotel and have a meeting. So, but in this case, most of the medical education is happening online. I think we have used a lot of Zoom, Skype, and Microsoft Teams and all these things to avail medical education to various people. And I would say this has been of great help that we already had these platforms prior to the pandemic, because without technology, I don't know how long we would have been able to give this education to our medical workers. Thank you, Stella.
Okay, thank you very much, Dr. Gitau, and our panelists, thank you very much. I also wish to thank Dr. Demola for taking the time and putting his best foot forward in juggling amidst our issues today. Much as we have had a few hiccups here and there, I believe that by and large, we have had quite an interactive session. I know that we have not been able to exhaustively discuss a lot of the topics that are of interest and that possibly we could be able to cover. And I propose that possibly going forward, we are going to possibly have more of this, because we need to look at going beyond all these innovations. How do we accelerate adoption of these technologies? How do we mainstream this telemedicine and the initiatives that have been discussed today? How do we enable an enabling investor environment in Kenya for the medical sector and for the health sector? So there is a lot more going on. We couldn't possibly have been able to do it in just 2 hours, because it's actually just over 2 hours since we started, and it seems like there's still so much more to say. So I would like to hand over to my colleague Josephine to take it up from there as she's heading towards closing. I kindly ask you to indulge us maybe for just about 5 more minutes. Welcome, Josephine.
Thank you very much, Stella. I think I have seen one question that I think we should address. And the question just says that health is devolved. How are the counties part of the overall strategy, looking at capacity in terms of financing, HR, and the current pandemic? So as we close, maybe we can have one of the doctors around, maybe Dr. Elizabeth Gitau, to give us some insights around the counties and how they are coordinating along the current pandemic.
Okay, thank you, Josephine. I hope you can hear me now.
Yes, we can hear you.
Okay, thank you. So in terms of the county preparedness to COVID pandemic, of course, the counties are playing a whole lot of roles within the response to COVID-19. So the counties, as you know, are in charge of all the facilities. So in terms of COVID response, we're expecting all the county facilities to be on the forefront in terms of funding the treatment, funding the quarantine for the people who actually need. Actually, the people, when it comes to the surveillance team, each county has a county surveillance team, and this is principally the role of the counties. The counties have also been allocated, I think, about 5 billion shillings, which they should be using in terms of procuring PPEs and making sure that their facilities are ready to take care of COVID patients. So, of course, most of the work, the national government will give a lot of direction in terms of policy and guideline management, but in terms of the actual work to be done, it will be done by counties. And I think if I was to mention one of the counties where we've had, apart from Nairobi, the other county where we've had majority of the cases is Mombasa. And as we have seen, the governor of Mombasa has been on the forefront fighting COVID. Possibly Nairobi county government has not been on the forefront because of the fact that, as you know, we already have a Nairobi Metropolitan, which has been coordinating a lot of the COVID response within Nairobi. But for sure, counties would be the forefront in terms of fighting this war.
Thank you very much, Dr. Gitau, for those insights. Just looking at the participants that we've had, we actually have representation from about 40 of the 47 counties. And so it was very important to get that conversation on the role of counties in really tackling the pandemic and also in the overall health sector agenda. And so thank you once again, all of our panelists, for really that engaging session, that we've had quite exciting conversations going, and the questions also complement the conversations that have gone. And just to tie this together, I want to invite David. David is our colleague and partner from Country Hubs Association. And at CODA, we are running an innovation challenge that is really now harnessing all of these ideas together to come up with solutions that can complement the needs we have at the moment and even in the future. And so to talk to us more about this, I want to invite David. David, please come on board and talk to us about the challenge.
Thank you very much, Josephine, for really very insightful. I'll be very brief because of time. So what we are doing now is, again, as a backdrop of this conversation, is that we are running an innovation out. And so together with CONSA, Countrywide Association or Network of Hubs, we were asking ourselves, what's the role of hubs? What's the role of innovators? What role can we play in making a positive contribution in this national dialogue? So the big game for us is to match the current challenges articulated by government and private sector to bring out scalable solutions. How do we co-create and adopt, and as well as match with policy and financial incentives of health? So we are looking at 3 areas. One is health. On health, Madam PS said that the Kenya can only test 600. How can we move this to hundreds of thousands? What about timed information, medical supplies, equipment? So the innovation could be in any area in terms of health systems. The second category is in food systems, agriculture sector. How do we scale the practices to reach larger farmers? How do we manage logistics to get food to the most vulnerable communities? Businesses are closed, but what goes on? So how do we manage online platforms in terms of ordering systems, shifts, and adaptations to the current business models? So we are looking at these 3 challenges, and we are calling upon all the innovators out in the country. So who can participate? It's open to all Kenyans. So startup teams, could be organizations, could be individuals, and this information is already out in our website. So if you visit CONSA website, maybe I'll be able to put it up. Oh, it's already there. If you visit CONSA website, if you visit Countrywide Innovation Hub website, you can be able to get this information. We are looking at all different types of ideas. So it could be in prototype stage, it could be in the tested stage, it could be the early stage. It really doesn't matter. The deadline, so also be mindful that the deadline is coming very quick because we are dealing with emergency situations. So deadline is 3rd of May. And then between 13 to 14, we hold the hackathon. And then we have an award ceremony on the 16th of May. And together with CONSA, we'll be able to offer the winners funding, technical, and hand-holding. So in terms of networks, how do we get to the next level? Of course, in terms of the funding, so it's more or less like will be decided by the partners. So we look really forward to welcoming more innovations. We want more Daktari Africa, Flare ambulances, Ilara Health, and the many innovations that I think were already discussed in this forum. So I want to give a special, of course, also shout out to our esteemed partners. I want to mention UK, Kenya Tech Hub through Shina. I want to mention Oracle, Cisco, Thunderbird, Microsoft. But at the same time, I'm appealing to more people or organizations really to come out and support us. And also in the same breath, we still will calling upon if you have technical skills as judges, trainers, mentors, please reach out. And of course, not to forget the amazing team from CONSA led by Engineer Tanui, Josephine, June, Lucas, and of course from my team in Countrywide Innovation Hub, Chepkemoi, Xavier, Dorcas, Ali. So please come forward. We only have 4 days left, and we really look forward to getting the best innovations for this COVID and past COVID. Over to you, Josephine. Again, thank you very much.
Thank you very much, David, for sharing the opportunity. As we've said, we've had a lot of interest about innovations. Where do we channel the innovations? And I think this is a very good platform and opportunity for us to come together as we innovate around the challenges facing us and also facing the health sector in Kenya and in Africa. So at this juncture, allow me to really appreciate all of us for coming together for this event. It has been 2 hours of engagements, of discussions, of asking questions and really learning from each other on how we can innovate around the health sector leveraging on technology. And so I want to thank all of our invited guests, all of panels, participants, and all of the speakers that have shared their insights. Thank you very much for this session. And also, we look forward to continue engaging in the topics. As you've heard, we've not been able to exhaust the discussion. So for future events, you're welcome to participate and join with us as we collaborate in this front. I also want to appreciate our partners. I think David mentioned we are working in collaboration with partners from the technology ecosystem, from the private sector, public sector, and development organizations. Thank you very much for that support. I think working together then allows us to look at all the facets of the challenges facing us and really pool our resources together to innovate. So just to mention, we have Microsoft, we have Huawei, Infonet, Cisco, Kipepeo Images, Oracle, Thunderbird Institute of Management, the UNDP, and the UK Kenya Tech Hub. So thank you very much for that support. We are still open for partnerships. And so we invite among us our participants, you're welcome to join us as we continue with this journey. Just to also mention that this is the second of the webinar series sessions we'll be having. We have one more coming up on Saturday, and that one will be about decent work, looking at the productive sector of our economy and how we can innovate around the work and the employment sectors, again, which are also really affected by the current pandemic. And lastly, I also want to appreciate our technical teams. We have, it's challenging to run an online event, maintaining decorum and protocol and just an environment where conversations can happen. And this has taken a lot of work from our technical team. Thank you very much, Ian, Lucas, and Magdalene, and the team supporting the platform to allow us innovate around the innovation challenge. And also to appreciate our moderator. I think our moderator, you have elevated our conversations, and we appreciate you for that time, for taking time out of your busy schedule and really coming in to support this hackathon. And I think and lastly, but not the least, also thank our CEO for this platform, for the opportunity to allow us to engage in these conversations and the support we are getting. We completely appreciate you. And I think we are happy to have such sessions moving on. So welcome to all of us to Konza City. When the pandemic is over, you're welcome to come and innovate with us. You come and invest, and together we build our city for Kenya and for our region and for Africa at large. And with those closing remarks, I want to say thank you very much for logging in. We look forward to having you in the next sessions. We will be sharing highlights of these conversations, as well as some of the discussions, summary points that have been shared. So please also be on the lookout for those in your emails. And would you have any questions? We'll also share an email address through which you can engage with us. Thank you again, and good afternoon.
Thank you very much. Thank you for having us, and best wishes. Thank you.
Thank you.